This is an instructional video meant to answer the most common questions and concerns from clinicians and patients regarding the OGAP OPL system utilized by the Osseointegration Group of Australia. It is a cursory overview and not a comprehensive guide to using the system. In this video, we will go over the names of the different components used in the system, the different types of prosthetic adapters that are utilized, maintenance and care to be performed by a prosthetist, what activities and restrictions are involved with the system, hygiene, use, and care of the system, and finally, special concerns in regards to prosthetic componentry. All OGAP OPL systems have the same basic components, even if the design of the components might vary. The system begins with the implant, which protrudes varying amounts beyond the skin at the end of the residual limb. Pressed into the implant is the dual cone adapter. This is held in place by a press fit and a locking screw. Onto the end of the dual cone adapter slides a taper sleeve and an anti-rotation bushing. These are both held in place by another locking screw. The pins that are attached to the bushing insert into the taper sleeve. These pins act as a breakaway point to provide a failsafe in case the system experiences extreme torsional forces. It is also important to note that the bushing comes with the pins in different positions depending on the amount of rotation desired for the patient. The degree of rotation is typically printed on the face of the bushing. Attached to the taper sleeve and bushing are the prosthetic connectors. There are two main varieties of these. Each, though, has similar function. The first type is often termed as an AQ connector. It has a locking or grub screw that must be tightened to secure the prosthesis to the taper sleeve and implant. The torque setting for this screw is 5 Nm. The system is also held on by a posterior clamp screw that must also be tightened to 5 Nm. It is important to note that these connectors come with varying offsets and angulations that are built in and are critical to achieve appropriate alignment. The second type is a MAC connector. This has many of the same attributes and varieties as the first type, although it is important to note that the MAC connector has much more versatility because of the ability to add on a male or female connector with varying offsets. The OGAP OPL system is very robust, but there are some items that may require servicing or regular maintenance. The first process we will discuss is attaching prosthetic components. There are two types of systems that are currently being delivered to the patients. Both systems require the patient to have a 4 mm and 8 mm Allen wrench on hand at all times to don and off the prosthesis. While it is not realistic for each patient to have a torque wrench available every time they put their prosthesis on, it would be helpful for a prosthetist to show the patient about how tight 5 Nm is for their reference. One of the most important points with this set screw is that it does not back out all the way. There is a collar on the screw that prevents this. As the screw is loosened and you feel a hard stop, do not turn the screw past this stop. If the screw is backed out excessively, then it can become jammed on its collar. Another process that may need to be done from time to time is changing the bushing. This can be necessary if the shear pins have broken away or if there is some loosening due to the shear pin rubbing loose. In order to change this, the locking screw holding the tapered sleeve and bushing must be removed. It is important to mark the alignment of the components before removing them to preserve the overall rotation of your prosthesis. To remove the prosthetic components only requires your standard Allen screw, but to remove the bushing and taper sleeve requires special tools provided by the Osseointegration Group of Australia. These tools allow the patient to stabilize the implant and femur as you apply torque to the locking screws. Install and stabilize handles by tightening the set screw into the groove on the taper sleeve. Have the patient or a helper firmly stabilize the implant by holding the handles steady. Warn the patient that they may feel a hard click or small jolt as the screw loosens. Be as gentle and smooth as possible while doing this, as it can be uncomfortable for the patient. It may require a good amount of effort to loosen this bolt. Once this bolt is removed, The bushing can be removed, inspected, and replaced. The last procedure that we will cover is checking the tightness of the dual cone locking screw. It is very common for this screw to require tightening at least once after the initial installation and surgery. This will be the case especially after the patient increases their activity and consequently sets the adapter more firmly into the implant. It is recommended to check this at least once after the surgery, especially if the patient is increasing their activity level. To access this screw, you must remove the prosthetic components as well as loosening the bushing and taper sleeve. Once these are all loosened, install and stabilize handles into the groove on the taper sleeve. Again, have the patient or helper firmly stabilize the implant by holding the handle steady. All parts must be cleaned and inspected regularly. If any movement within the system is ever seen, the system needs to be checked by a prosthetist to see if any wear or settling has occurred or if any loosening has occurred as well. The OGAP OPL osseointegration system has the main goal of increasing comfort and quality of lifestyle. This does not mean that it allows the patient to return to all previous activities. There are some guidelines and restrictions that are recommended. Generally, the patient should avoid any situation that would expose the stoma or opening around the dual cone adapter to excessive amounts of bacteria. This could lead to dangerous infection. Also, activities that could create sudden twisting or bending forces or torque on the implant is not recommended. High-impact sports are discouraged. If an impact sport is engaged in, it is recommended that a protective socket be manufactured by a prosthetist to distribute the loads to the soft tissue as well as the implant. With regards to running, there is no official stance on whether or not you are allowed to run. High impact is discouraged within the system. However, if some light running is to be participated in, it is recommended that the patient wait a year for full bony integration to take place. Exposure to water is okay, but there are a few guidelines that should be observed. Public pools and lakes are notorious about having high bacteria levels and should be avoided. If swimming in these areas is desired by the patient, then the prosthetist may want to look into creating a protective covering for the stoma using a silicone liner. Salt water is healthy for the stoma and is encouraged, as well as Epsom salt baths. For all water activities, the same warranty guidelines of the standard prosthetic components still apply. The typical rehabilitation timeline following surgery is as follows: 2 crutches with partial weight bearing for 6 weeks, and 1 crutch weight bearing for the following 6 weeks. This general schedule will be tailored and changed as needed by the surgeon for each individual patient. Some issues that may prolong this timeline are degree of osteoporosis, other procedures performed such as hip or knee implants, and any other comorbidities. As mentioned previously, full bony integration typically takes place by the 1-year mark. This is also the time when substantial bone density returns. One of the most critical elements in working with an osseointegrated patient and limb is good hygiene. The stoma, or opening around the dual cone adapter, requires some extra attention and care to ensure that it remains healthy and not susceptible to infection. The most important step to remember is to wash the opening twice daily with soap and water. For the first several months after surgery, and perhaps even longer, there will be some fluid discharge from the opening. This is completely normal. If the fluid is excessive, nursing pads can be used to help prevent the fluid from staining clothes. If the fluid is not clear or contains excessive amounts of blood or has an unusual smell, please contact your osseointegration liaison or a physician. Other steps that help promote healthy limb are exposure to sunlight, Epsom salt baths, and generally keeping the area clean. When working with the prosthetic plan for osseointegrated patients, it is critical to understand the biomechanical differences once the socket is removed from the picture. One of the biggest differences is the amount of shock absorption and cushioning that is lost. In an intact leg, shock absorption comes from 3 places: the fat pad on the bottom of your heel, from your ankle movement, and from your knee movement. In traditional prosthetics, this is achieved through prosthetic components, but also some is achieved through the cushioning of an elastomeric liner and from the compliance of the tissue against the socket. These 2 shock absorbers are now gone, so much more care is needed to provide shock to these patients. Another difference is that there is a certain amount of play in every socket that helps reduce shear forces and torque on the knee and hip. With an osseointegrated patient, this absorption is also gone. For these 2 reasons, the components needed must provide good shock and good ground compliance. This can be achieved by any combination of the following components: flexible or dynamic feet, soft cushioned heel, shock absorber, or torsion adapter. Of course, it is possible to make a system too compliant, which would increase the energy expenditure of the patient, so care should be taken to find a good middle ground for each patient depending on their size, amputation level, and activity. For transfemoral amputees, it is highly recommended that a knee rotator is used. This has been proven to reduce long-term pain when sitting with the prosthesis. By pushing the button on the rotator, it releases the small amount of tension that is applied to the hip and implant. It is also highly recommended that transfemoral patients receive a microprocessor-controlled knee. This is for several reasons, but primarily for the added safety that has been proven to come from this type of knee. We hope this video has been helpful in answering any questions or concerns you have had. If you have additional concerns, please feel free to call or email the U.S. Liaison for the Osseointegration Group of Australia, Fred Hernandez. Thank you.